Hello everyone, I am Dr. KAUSTAV Datta, postgraduate trainee first year, Department of Radiodiagnosis, Kalinga Institute of Medical Sciences, Bhubaneswar, Odisha, and I'll be presenting a paper here regarding a pictorial review of the CT signs of blunt and penetrating injuries. My guide is Dr. Krishna Chandra Viswal, Professor, Kalinga Institute of Medical Sciences, Department of Radiology. Aims and objectives. Aim to describe the CT signs of blunt and penetrating diaphragmatic injuries seen on CT. Objectives to represent through CT images the various signs to be looked for in blunt and penetrating diaphragmatic injuries. Materials and methods. Trauma CTs from the PACS database were obtained using search words such as diaphragmatic injury, diaphragmatic rupture over a period of 15 years. The images were reviewed to look for the direct and indirect signs of diaphragmatic injury. Introduction. 3 to 8% with blunt trauma and 10% of penetrating trauma patients can have traumatic diaphragmatic injury intraoperatively. Missed diagnosis may have serious consequences like intrathoracic visceral herniation and strangulation, leading to mortality. There are various direct as well as indirect signs that are useful in identification of diaphragmatic injury. Multidimension CT is the imaging modality of choice. Introduction. Blunt diaphragmatic injuries are due to the impact of trauma and sudden rise in intra-abdominal pressure that occur at the weaker parts of the diaphragm, usually posterolateral aspect. Penetrating injuries can occur along the trajectory of the weapon, smaller in size and variable in location. Management is prompt primary surgical repair as soon as the diagnosis is made. Then anatomy of the diaphragm. Diaphragm is dome-shaped. Circumferential attachment to chest and the abdominal wall is seen. There are two muscle groups, the crural and the costal, both insert into the central tendon. Then attachment of the central tendon anteriorly in the posterior aspect of xiphisternal junction, posteriorly L1 to L3 vertebral bodies, and laterally 6th rib anteriorly and 12th rib posteriorly. Then we can CT the anatomy of the CT diagram in this image. Here is the right crus of the diaphragm and the left crus of the diaphragm, and in the coronal image we can see the costal insertion of the diaphragm. Then signs of diaphragmatic injury. The direct signs is direct discontinuity of the diaphragm and dangling diaphragm sign. Indirect signs are dependent visceral sign, like when a patient with a ruptured diaphragm lies supine on a CT examination table, the herniated viscera like the bowel or the solid organs are no longer supported posteriorly by the injured diaphragm and fall to a dependent portion against the posterior ribs. Then the collar sign or the hourglass sign is a waist-like constriction of the herniating bowel viscus from the abdomen into the chest at the site of the diaphragmatic tear, which is classical for diaphragmatic rupture. Then intrathoracic herniation of the viscera can also be seen. Contiguous injury on either side of the diaphragm can be seen. Then sinus cutoff sign can be seen. Other signs could be segmental non-recognition of the diaphragm, then focal diaphragmatic thickening, and intrathoracic fluid aborting the abdominal viscera. Then direct signs. Direct discontinuity of the diaphragm. Direct discontinuity of the diaphragm visualized along with the segmental non-visualization of the diaphragm. As you can see here in the image, there is discontinuity in the left diaphragm. Then direct signs. Dangling diaphragm signs. It's an identifiable free edge of a torn diaphragm curling inwards towards the center of the abdomen away from the chest wall. Here in this image you can see the diaphragm dangling down and curling inwards towards the abdomen. Here also we can see the same. Then indirect signs like intrathoracic herniation of the viscera. Appearance of an intra-abdominal organ within the thoracic cavity through a defect in the diaphragm. Here we can see there is a defect in the diaphragm and we can see the abdominal viscera like stomach is protruding into the thoracic cavity. Then indirect signs like dependent viscera sign, where we can here you can see upper 1/3 of the liver aborts the posterior ribs on the right side, or stomach and bowel aborts the posterior ribs and lies posterior to the spleen on the left side. Then indirect signs like collar sign, focal waist-like constriction of the herniating abdominal viscus at the level of the torn diaphragm. This is the hourglass sign. It's a waist-like constriction of the abdominal viscus herniating through it. Then indirect signs: contiguous injury on either side of the diaphragm. Contiguous injuries on both sides of the diaphragm implies transdiaphragmatic penetrating injury. Here we can see a liver laceration and a lung contusion. In diaphragmatic trauma, mechanism of injury: there could be blunt trauma or penetrating trauma. Blunt trauma occurs due to sudden increase in the intra-abdominal pressure. It's larger and radial tears that occurs more frequently on the left side due to congenital weakness of the diaphragm on the same side and attenuation of some force by the liver. Higher rate of injury to the aorta, lung and pelvis, spleen. Whereas penetrating trauma causes smaller tears more frequently on the left side. Most common cause is stabbing on the left side because assailants are usually right-handed. Then higher rate of injury to other organs like liver, hollow viscus and spleen. Here is one case where a 30-year-old male came to the department with blunt trauma to the abdomen. There is plain radiograph which is showing elevated left hemidiaphragm with loss of contour. Then in the CT we can see a dangling diaphragm sign and a different dependent viscera sign. This is the dangling diaphragm sign and the dependent viscera sign. Then diagnosis: it's a blunt left diaphragmatic rupture. The intra findings showed is 7 into 7 cm posterolateral avulsion of the diaphragm with herniation of small and large bowel, spleen and stomach. The management was primary repair and it was done as soon as possible. Then case 2, it's a 17-year-old male came with a penetrating injury by a bull gore to the anterior abdomen. The CT showed anterior diaphragmatic injury with herniation of the left lobe of the liver and transverse colon and omentum. Here is the herniating transverse colon along with the omentum. Then the diagnosis is the anterior diaphragmatic injury with traumatic visceral ventral herniation. Management is primary repair with closure of the wound. Herniated omentum and left of the liver can be seen here. Conclusion: diaphragmatic injuries may be frequently missed due to more severe associated injuries with serious late adverse effects. Multidirector CT is the investigation of choice and it is important to review the images in all three planes. It is imperative for the radiologist to be aware of the various direct and indirect signs to identify injury to the diaphragm in any case of trauma. These are my references. Thank you.